methadone is like substituting one drug for another, I really want to dispel that myth. When people have opioid use disorder and they're using drugs like heroin, like fentanyl, the experience of that is really dysfunctional for somebody's life. They experience highs, lows, withdrawal. Often their life gets out of control. They're using despite ongoing harm. And when somebody's ready for recovery and they want to be on methadone with their recovery plan, what the methadone does is it's actually a medication that treats the addiction. So by no means is it a substitution. Somebody going on methadone will experience relief of the withdrawal, reduced cravings, and ultimately they usually stop using opioids. This medication is very similar to other medications that are used for chronic diseases like high blood pressure, like diabetes, where there are behavioral things that we ask people to do: change your diet, change your exercise, lose some weight, eat differently. And when you're doing all of that and the medicine is, and the disease is still sort of out of control, we add medications. For people with substance use disorders, adding methadone can really be the difference between getting into a long-term path of recovery and really still having cravings and withdrawal that make it really hard to stop using. It's really dangerous when people consider treatment centers to be equivalent to pill mills. That is, in my mind, using the stigma of the disease of addiction and the stigma against the treatment together in a way that inhibits people's desire for care. And so it creates a dangerous combination that I think is leading to additional overdose for our patients because they're afraid of treatment. I would phrase it really differently. I would say that if somebody's choosing to go to a center to get treatment for their addiction, it's very much like choosing to go to an urgent care if you're worried you broke your finger, or your doctor's office because you want to have control, you want to have management of your diabetes. So going into a medical center to get treatment for any chronic disease is the same. So whether it's urgent care, a substance use disorder treatment program, or a primary care office, all of those places are places where you get the treatment for the chronic disease that you have. So absolutely not a pill mill, really a place of recovery and support. This is another great myth. Methadone being like the thing we're going to use last when everything else doesn't work. I would totally disagree. Methadone is one of the medications that is approved for treatment of opioid use disorder, and we've only got 3. That medication, methadone, has been around longer than the other 2. Both buprenorphine and naltrexone have been around for a while, but methadone exceeds them all. Started use in the 1960s. We have more data about that medication than any other medicine we have. What it does is not only helps reduce people's use of opioids, reduce their cravings, reduce their withdrawal, help them stabilize in long-term recovery, in addition, reduces HIV, hepatitis C, and incarcerations, as well as reducing use of other drugs. There is no medicine on this planet that does more for chronic disease than methadone. And so really, I think we should be flipping that myth on its head and saying, hey, when you're coming into treatment, we're going to offer you all 3 of these medications, but particularly the 2 that reduce the risk of overdose death. And I think that's key. Methadone and buprenorphine are the only 2 FDA-approved medicines that reduce the risk of death for people with opioid use disorder. A lot of times people will come into treatment and say, hey, how long do I need to be on this methadone? And I think one of the first questions I'll say is, let's back off from that and say, what are your recovery goals? For some people, their goal really is to use medication for a short period of time. And for some that may mean 6 months, for some that may mean 2 years, for some that may mean longer, but they want to use the medication to help them stabilize. And then their goal is to slowly come off that medicine. For other people, they have a much more open-ended relationship with the idea of medicine. And I like to say that if you think about substance use disorder treatment, so we're talking about opioid use disorder being treated with methadone, compare it directly to high blood pressure being treated with a medicine like lisinopril. So when a patient is needing medication or is choosing to be on medication for these 2 chronic diseases, a lot of the decision goes into, is the medicine working? Are there major side effects or problems related to the medicine? And is it doing what we want to reduce the activity of the disease and to help that person achieve the long-term recovery results they look for? For some people, the medicine will be really effective and really beneficial for a period of time. And then as part of their recovery journey progresses, they're going to want to come off that. We can do that slowly over time. Generally, it takes months, if not years, depending on how long you've been on methadone, to taper off in a way that doesn't put you at risk for increased withdrawal and then possibly return to use. In the same way, though, if somebody's on a medication, like methadone, for example, and it's working, and it's helping them sustain their recovery, and the pressure that they get from the outside world is, hey, get off that medicine. You've been on that too long. Isn't it time for you to be truly sober and come off the medicine? That's a hard place to be. When medicine's working, to say to somebody, hey, the medicine's working, but now it's time for you to come off, really isn't how we treat other chronic diseases. So now let's go back to our high blood pressure. If somebody's on their lisinopril and their blood pressure's under control, and we say, oh, this is great, this medicine's working, now let's take you off it. We'd all say, what are you talking about? The medicine's working, I should stay on it. So I do want to emphasize that if somebody's choice is to come off medicine, we'll certainly help them with that. At the same time, we want people to know that methadone is one of the 2 medications that reduces your risk of overdose and death. And so if you're going to choose to come off that, you lose that protection. So we want to make sure that you have a really solid, robust recovery that's going to support you if you choose to come off the medication. It is true that methadone is an opioid medicine. And if somebody were to take methadone and not have any opioid tolerance, if they were to use it recreationally, for example, then you certainly could become impaired. It's an opioid. But methadone for the treatment of opioid use disorder is not something that people use to get high. It is a medication that will have its onset where you start to feel it working within 30 to 60 minutes. It gets to its peak level in your blood about 4 to 6 hours later. And then once you're on a stable dose, it actually stays in your body for a full 24 hours. So taking a dose once in the morning lasts all day. People describe feeling normal. What they describe is feeling no longer having the withdrawal, no longer having the cravings, and really being back to their usual self where they can work, they can parent, they can do the things they want to do in their lives that really got interrupted when they were using. So methadone is one of those medicines that, because it is so long acting, because it is so slow to have its onset of action, and because it's really been well studied for decades, it's a medication that is, I think, in the category of medicine and not in the category of a drug that people use for abuse or for the purposes of getting high. It's really a very solid medication. A lot of people are worried about the impact that people have described having, like an impaired ability to think or to make decisions when they're on methadone. And I think that there are 2 sides of this. On the one side, methadone is an opioid medicine, and all opioids have the potential to cause side effects, such as if they are in a dose that is too high for the person who's taking the medicine, it can make you feel a little groggy, make you feel a little bit fuzzy and foggy in terms of your thinking. On the other hand, if you're on a dose that is correct for you and has been stabilized and you're not experiencing interactions with other medications or other medical problems that you may have, most people who are on methadone feel normal. They feel like themselves. They don't have periods where they don't feel like they can think correctly. They just look and feel normal. A lot of times when I have patients or family members who have a concern about their loved one choosing methadone, they'll say to me, but doc, aren't you going to be able to tell they're on methadone? Like, aren't they going to be sleeping all day or having their heavy eyelids nod squad, people say. And I say, you don't know that I'm not on methadone. So what you should see when somebody's on methadone is exactly what you see here. Any of us who look like a functioning adult human on the planet could be on methadone. So you really shouldn't be able to tell if someone's on methadone. They just look fine. And one of the things that I think all of us can do to help support people who are on methadone is, if you know someone who's getting this treatment and they don't look fine, make sure you talk to them and make sure you talk to their methadone clinic to have that communication and readjust the dosing to make sure that person is safe. being at an opioid treatment program is really different from being at a doctor's office. However, Brightview really blurs the lines so that when you come into a Brightview facility, it doesn't feel like a methadone clinic. It feels like a doctor's office. And the experience is really wrapping our systems around the patient to make sure they have the support they need.